I'm Professor Bazerbachi. We're going to have a keynote lecture now by Professor Bazerbachi about multiple myeloma, past, present, and the future. It's going to be followed by a Q&A session for both our speakers. Then it's going to be followed by a symposium by Dr. Ali Bazerbachi. The floor is yours, Professor.
Thank you, David. صباح الخير. وبحب أول شيء أتشكر نقابة أطباء لبنان في طرابلس على الدعوة الكريمة. هيدي نقابتي، هيدي مدينتي، و it's always an honor and a pleasure to be here with you. I will go through another example. So we have seen with Dr. Jean Sheikh the success in targeted therapy of chronic lymphocytic leukemia, and I will go with you through another disease, multiple myeloma, and see how the advances have transformed this deadly disease into now a chronic disease where people have almost a normal life. So the landscape of treatment of multiple myeloma has changed significantly in the last 50 years. So for many decades, the only treatment available was melphalan and corticosteroids. And this was actually the combination of melphalan and corticosteroid was invented by an American Armenian doctor of Lebanese origin called Alexanian. And the first advance was in the 1980s with the use of high-dose melphalan and autologous stem cell transplant. Then we started to see targeted therapy of multiple myeloma, first with a very old drug that was banned for a while because it causes abnormalities during pregnancy, thalidomide. And thalidomide is extremely effective in multiple myeloma, we'll see that. Then new generation cousins of thalidomide, IMiDs, like lenalidomide and pomalidomide. Then we have proteasome inhibitors like bortezomib, monoclonal antibodies targeting myeloma cells like daratumumab, and now we have immunotherapy with bispecific antibodies and CAR T cells. So where do we start from? Long time ago, we talked about this first standard of melphalan prednisone. In the 70s, I was already born. I was born in 1965. Combination chemotherapy, including alkylating agent, improved the response rate versus melphalan prednisone. But we were talking about only some response, what we call the plateau of myeloma, but did not improve survival. And in the 80s, alpha interferon was added to chemotherapy induction, and particularly as maintenance treatment to maintain the response. It improved the response rate, but 3-year survival remained in the order of 50%. So we're talking about half of the newly diagnosed patients who were dying in the first 3 years. And when you look to this book, the Harrison, you all know Harrison, Principles of Internal Medicine, about 15% of patients die in the first 3 months after diagnosis. And subsequently, the death rate is about 15% per year. And the disease usually follow a chronic course for 2 to 5 years. So basically, in the Harrison, multiple myeloma, when you have a multiple myeloma patient newly diagnosed, it means it is a death sentence and that the patients are going to die within few years. That was a long time ago, but most of us were already born. And the first step was in the 1980s, so in the 2 decades, from 1980 until 2000, the advances in myeloma therapy were mostly due to autologous stem cell transplantation. So the principle of autotransplant, the transplant itself has no anti-myeloma treatment. It only allows the patient to survive the very high dose of melphalan that we are giving to kill the myeloma cells with the principle of dose intensity. So when we give high dose of melphalan, we kill the myeloma cells, but we kill the normal bone marrow, and the autotransplant allow the patient to survive. And you started to see improvement in overall survival. And in multiple randomized trial, you can see that patients who received conventional treatment had a 5-year survival of 12%, whereas with autotransplant, we're talking about 52%. So the lessons from this first step is that high-dose therapy and autotransplant improve progression-free survival. With deeper response, we start to see a complete remission, and this became standard of care for newly diagnosed patients as long as they are young enough and fit enough. Today, standard up to 70-year-old. We discuss case by case between 70 and 75. The second step, which was the recent past, I mean, this is not a long time ago, 2000 to 2015, the thalidomide, lenalidomide, and bortezomib. These were the 3 drugs, and thalidomide was a drug that was, as I said, banned because it causes problems to the embryos and to the fetus, and women were taking it for nausea during pregnancy, and then we had children born without arms, without legs, and then someone a bit crazy in Arkansas started using thalidomide to treat myeloma patient called Bazerbachi of German origin, and it worked. And then combination of thalidomide with dexamethasone or with alkylating agent, and later on, another miracle in myeloma treatment was the use of proteasome inhibitor. So it targets the recycle bin in the cell, in all cells, but this is very important in myeloma cell. It blocks the degradation by the proteasome, and then the cell, like myeloma, that has a lot of abnormal protein to recycle, when you block the recycling, the myeloma cells were dying. And bortezomib was introduced in the treatment of multiple myeloma, mostly by the IFM French group by Jean-Luc Arousseau. And you can see here the meta-analysis of multiple trials showing improvement in progression-free survival when we use bortezomib during induction. And then combination, always when you have 2 drugs that work, you combine them together. So the IMiD, thalidomide or lenalidomide, the bortezomib, and the steroids, the VTD and VRD regimen became very popular and represented, until recently, the standard of care of induction treatment before transplant. You do the transplant, and the patient, and you stop. If you stop treatment, this is not curative. Patient will start to relapse. So we started to use drugs to prevent relapse. And the first attempt and success was using thalidomide to prevent relapse. And it worked beautifully, improving overall survival. But thalidomide has some side effect. It causes somnolence and constipation. So another cousin of thalidomide called lenalidomide was used, and as maintenance, you can see here combining from meta-analysis of the French group, of the American group, and the Italian group, showing that progression-free survival improved from 23 months to 52 months, and the overall survival at 7 years improved to 62%. So you remember, we had 12% of patients alive at 5 years. Now, with this advance, we're talking about 62% of patients alive at 7 years. And the 5-year survival in multiple trial with a triple induction, which was the standard of care, VRD induction, auto-transplant, and lenalidomide maintenance, we're talking about 75 to 80% of patients who remain alive at 5 years, and it takes 4 to 5 year median for patient to relapse. So this was a major progress in myeloma therapy. So the lessons from this second step is that in transplant-eligible patient, new induction and maintenance improve the median PFS from 2 years to 5 years and beyond. With better salvage treatment, the 5-year survival improved to 80%, and the major prognostic factors are the genetics of the myeloma cells and the response to treatment. So the depth of response. So in the 1970s and 80s, we were happy to get a response. Then we were happy to get a complete response. And then we are happy now only if we get what we call MRD negativity, so minimal residual disease. Basically, when you diagnose a patient with multiple myeloma, you have 1 kilo of tumor, which is 1 trillion cell, 10 to the power 12. We say complete remission when we don't see the myeloma cell on the bone marrow. This is when you are below 10 grams. So you went from 1,000 grams to below 10 grams, which is 10 billion cells still. MRD is detectable at 10 to the power 8, 100 million cell, which is 100 milligram or less than 0.1 gram. So you see the extent of depth of response, and basically the impact of MRD negativity, when the more MRD negative, the better is the outcome. So the third step, 2015 to 2020, which is kind of the present standard, newer IMiD, newer proteasome inhibitor, and anti-CD38 monoclonal antibodies. So now we have a newcomer, which are the monoclonal antibody. Like in lymphoma, we used to give CHOP, then R-CHOP, and you double the survival. Now with myeloma, we have the addition of monoclonal antibody targeting CD38, like daratumumab, And this is a major European study, the Perseus trial, randomizing VRD versus DARA VRD. And you can see the improvement in progression-free survival. So now at 4 years, 84% of the patients are still in remission. So they have normal life. And after this is a kind of plateau. And the survival is just outstanding. I mean, nobody is dying in the first 5 years, or less than 10%. And this improvement in progression-free survival was seen across all different subgroups. And this is associated with a major increase in complete remission, but also in MRD negativity that we talked about. You see that we are having 3/4 of the patient achieving MRD negativity at 10⁻⁵, which is 10 million cells, and 2/3 of the patient achieving MRD negativity at 10⁻⁶. So here we are talking about 1 milligram, less than 1 milligram of remaining myeloma cells. So in summary for this induction therapy, so we moved from chemotherapy with alkylating agent to thalidomide, bortezomib, triplets, VTD, VRD, DARA VCD, DARA VTD, DARA VRD. The standard for autotransplant remains high-dose melphalan, and post-transplant maintenance, now lenalidomide, and probably addition of anti-CD38. So today, in 2025, when we have a newly diagnosed patient with multiple myeloma, the first question is the patient transplant eligible? And we said yes for almost everybody until 70, and case by case between 70 and 75. And then we give induction, transplant, and maintenance. But still, even after 5 years, 6 years, 7 years, 8 years, patients will relapse. And in myeloma, patient will relapse. Then they receive treatment for relapse. They go into another remission that is shorter than the first remission until the disease becomes refractory. And then when the disease is refractory, what we call the triple class refractory patient, thanks God this takes 10 years to reach the triple class refractory, but this is a problem because patients are refractory to the proteasome inhibitor, to the thalidomide or lenalidomide, to the IMiDs, and to the monoclonal antibody. And these patients used to have a very poor survival. But another major revolution in myeloma therapy came, which is immunotherapy. And so immunotherapy is redirecting the immune system, the T lymphocytes, to attack and kill the myeloma cells. So normally in a patient with multiple myeloma, the immune system is not very effective because otherwise it would have killed the myeloma cells. So we should help the T lymphocytes to do that. And there are 2 ways of doing that, either using what we call bispecific antibodies, which are antibodies that have 2 ends. One is anti-CD3 that will bind to the T lymphocyte, and one is for example, B-cell maturation antigen that will bind to the myeloma cell. So the bispecific will make a bridge between the T cell and the myeloma cell, and the T cell will become a serial killer of the myeloma cell. Another way of doing the same is to take the T cells from the patient to introduce through a lentiviral vector, a new gene that will make a receptor on the surface of the myeloma of the T cells, and we re-inject them back to the patient. These called chimeric antigen receptor T cells or CAR T cells, and these CAR T cells injected to the patient will become a serial killer. So this is the overview of the global CAR T cell process. So we evaluate the patient, we take the lymphocytes by lymphopoiesis, we introduce ex vivo the viral vector, we expand the lymphocytes, we give chemotherapy lymphodepletion to the patient, and we re-inject the CAR T cells and we monitor them. So this process can take 4 to 8 weeks. And now we have approved CAR T cell therapies for triple class refractory or exposed patients, what we call the ide-cel or cilta-cel. And there are different trials that compare these in patients. You see 84 and 88% of the patients are triple class refractory, and median prior therapy, 6 lines of therapy. And you have a significant induction of overall response rate, 70, 80%, and the survival that is becoming, remember how poor was the survival for these refractory patients. And this is the same for example, in this trial, we have half of the patients that are progression-free at 3 years and median survival not reached, and we have a plateau at 60%. So these are making some revolution, particularly in the fraction of patients who achieve complete response to immunotherapy. These are the majority of patients, and these are, have a big benefit. So nothing comes for free. We have side effect with CAR T cells, and 2 types of side effects. The side effects that are specific to the CAR T cells, one is called the cytokine release syndrome. So this is like a septic shock, but no infectious agent. So patients are hypotensive, they require pressors, sometimes oxygen therapy, and this is due to the release of the cytokines by the T cells, similar somehow to what happened during COVID-19 infection. And the other one is neurotoxicity, and thanks God it is relatively limited in small percentage of patients. The other type of side effects is similar to autotransplant, is cytopenia, so neutropenia, thrombocytopenia, but this is something all hematologists are used to manage. And when we move now to the bispecific antibodies that are off the shelf available, one of them, for example, is teclistamab. This is the MajesTEC trial, and you can see 63% of overall response rate. Most of them are complete remission or stringent complete remission. And again, in this population of very refractory patient, major improvement in progression-free survival. So side effects similar to the CAR T, but much less with the bispecific. Efficacy similar to the CAR T, but a little bit less. So this is kind of mini CAR T, and infections and cytopenia are important. This is another bispecific elranatamab, and similar results. You see outstanding survival curve in patients who used to live for 3 to 4 months. Now they are living for a year. We have to make sure they don't get infections, and to monitor the immunoglobulin level, and to give them prophylactic antibiotics, and sometimes replacement by IV immunoglobulin. And even when patient relapse now after one kind of immunotherapy, we can choose another target and another type of bispecific, and you see that in these patients, again, we are getting very high rate of response exceeding 70% and 75% in this trial in the triple class refractory patients. So if these treatments are so effective in refractory patients, why not to move them earlier? And currently there are multiple trials trying to bring the CAR T cells or the bispecific to earlier lines of treatment. These are for CAR T cells, and you can see here in these two trials, and this is when we compare for earlier relapse CAR T cell versus standard chemotherapy. CAR T cell is superior in response rate and in progression-free survival. And this is cilta-cel, even better in terms of response rate and progression-free survival. And now even ongoing trial, I don't have results, are moving this immunotherapy frontline CAR T cells or frontline bispecific to the first line of therapy. So in conclusion, it is increasingly recognized that the most effective regimen should be used up front because we have real-world attrition of patients. So when we see results in the relapse setting, we assume that 100% of the patients who relapse are getting the treatment of the relapse. The reality is not less than 100, so all those who are not getting treatment are lost also. MRD-guided therapy is likely the future. We have seen the old and novel cellular therapy, the immunotherapy transforming multiple myeloma, and better understanding of the resistance mechanism will hopefully change myeloma to a curable disease. Now we talk about chronic disease with long-term disease control. And you see here the survival over time. So this is the era of 1989, 1999, 1999, 2008, 2009, 2018. And this is by age group. You see that for young patients until 65, now survival, 5-year survival, how it is increasing. But this is also true for 66 to 70, 71 to 75, 76 to 80, and even patients above 80, their survival is increasing. So never give up. Thank you for your attention.